Okay. So thank you for those who can't be here. We're going to be doing a trauma talk today. So we have Elena Tirador. She's a BSN RN and CCRN. She has 8 years in nursing altogether in the ICU. And she likes making handmade cards, which I find adorable. We also have Natalie Durkovich, who's also RN BSN. She actually graduated from the UCAN program. And you can sleep when you're dead was her motto. And I absolutely agree with you. That is a horrible program. But she spent 5 years total as a nurse, and specifically in the ICU. But she also did 3 years as a healthcare tech in the ICU that we all work at. So in the CICU. And so guys, just we'll leave it up to you. Talk about what you want, what you think it would be good for us as student nurses to know about trauma in the ICU. I've got questions too if you're like completely blanking, so no worries.
I guess does everyone graduate in December of this year, or what's your guys' graduation date?
We'll graduate in May.
Graduate in May? Oh my goodness. Okay. It's September. Okay. So you guys are coming up. And what clinicals have you guys had so far?
So Meg and I are in orange groups. So we've had complex care, like MedSurg 2. We've had OB, mental health, and we do peds next. And then Heidi, you're in the junior cohort. You guys are just doing like MedSurg 1 right now and Pharm, is that right?
Yes, that's correct.
Okay.
You guys have already done your complex care clinicals?
Yeah.
Whoa. That was like our last one, I feel like, before capstone.
Yeah, they have it set up a little differently for each of the color groups, but
okay. So you guys have gotten a little bit of exposure to a few different things.
Mm-hmm. Yeah.
But you guys are all interested in trauma or just curious about it?
I think a lot of people are just curious about it because we don't really get talked to a lot about it beyond like primary and secondary assessment. So yeah.
Yeah, I'm definitely interested in like the kind of OB triage, OB trauma type area. So some aspects of it for sure.
Which that's definitely a whole other beast, which is terrifying to non-OB people. As soon as we hear code white, we're like, don't come here, don't come here. But I feel like it's the same principles, stop the bleeding, monitor labs, always ABCs. That rule can like get you through pretty much everything. If you're stumped, just repeat the ABCs. Always, always, always. Airway, breathing, circulation.
And you got to say mama before you can say baby. That's all I know. And you put them on one side, but I don't even remember what side you're supposed to put them on when they're bleeding.
Which everyone doesn't like clamp the baby off the IVC or whatever. I think it's left side down.
I think it's left side too.
Yeah.
Well, here's my dog.
Hi,
well, I guess I don't really know where to start. I mean, trauma is pretty crazy. I think like one thing that I didn't really realize going into trauma is that it's actually just as traumatizing for us as nurses. Like we see some of the craziest accidents you'll ever witness, like whether it be like someone that's been dirt biking their whole life and now they're paralyzed, or they get assaulted and their life's going to be changed forever, or in a major car accident, or they are in a car accident and they lose their family member, but they make it, but they still have like a whole long road ahead of them. So I think when I went into trauma, like didn't really realize how traumatizing it was to me and how like scared I became. Like I always feel like I need to wear a helmet now. And I feel like I lived life like kind of wildly until I started seeing all these people get hurt and injured. So it was really important for me to make sure I have like outlets and ways of like coping, and how I can like handle that stress, and witness these things. That to me was the most shocking, but then again, it's also pretty cool because you see people go through these major things and they actually have a good life ahead of them. And they are so sick sometimes they're almost gonna die, and then they make it and they walk back in, and it's pretty awesome.
Hi, Joe. And Heidi, you had a question?
Yeah. So on your guys' first day as an ICU nurse, what was one moment where you felt like you just didn't know what to do? For example, let's say you were in a situation where you were like, oh crap, I don't know what's going on. I don't know how to handle the situation. And what did you do to bounce back from it?
Oh God, that happens all the time. It's not just first day. Yeah, that's ongoing. But the best part is like the way they have it set up, at least in our ICUs, you have like pod mates. So you're never isolated and alone. And you always have like someone to go to, whether it's your direct coworker, your charge nurse, the resident, the attending, like you always have phone a friend people around, and I wholly encourage people to just like know what they don't know and ask for help. And that's no shame whatsoever.
Yeah, I agree to that. I think a long time ago you would hear like nurses eat their young, and I feel like over time that motto is just like so out the door. It's now like you're trying to raise nurses and help each other, and the team aspect of where we work is the best place I've ever seen as far as teamwork goes. But you always have people around you that can help you. But like Natalie said, we have those situations arise every single day where it's like, I've never seen this before, and experience is everything. So once these things start happening to you, then you know how to handle them. But the first time they happen to you, you almost always don't know what to do. And there's people around you that can help you. My first day was as simple as a blood pressure was 170 on my patient, and I didn't know what to do. I knew it was high, and I wasn't supposed to have it that high, but I was like, I don't know what to do. I went and got
Your pressure's off. Yeah.
Yeah, and I gave a drug, but like I was like, oh God, their pressure's high. What do I do? And it was something so simple, but it scared me, right? Because it was the first time I ever had to deal with it.
And if it's
Everybody, my
something
name's
complicated,
Joe.
like,
Oh, sorry.
oh, go ahead, Joe.
Oh, sorry, I was late. My name's Joe. I work with these two wonderful ladies here as well, and I'm just kind of echo what they said. Every day, I mean, nobody knows everything, and there's a lot of days you're like, I had no idea what to do in this particular situation, and I really relied on my charge nurses who had lots and lots of years of experience. But you also have tons of resources too, like micromedics and other doctors in your unit that you can consult with. So no one's asking you to know everything, but you need to know where to find the answers to those questions, I think is the big thing. And to, admit that you don't know everything, I think kind of like Natalie said, because every day you learn something new. And then, that science will change and there'll be something new we have to learn in 5 years from now. So it never stops.
Yeah, focus on because our unit and hospital should always be evidence-based. And so evidence is always changing and evolving. And so the person who might have 30 years experience might not know the new way that evidence is showing to do things. So it's keep your mind open and keep your practice fresh.
Yeah, that's an excellent point, because a lot of people will do things just because they're comfortable with that way or that scenario of doing things, but it's not based on evidence. So we really should be practicing with that in mind for sure.
Thank you. I also have another question. I'm sorry. I'm just very intrigued about trauma and ICU mostly. And what is, I know it's extremely stressful from what your guys' conversation is so far. And what do you guys do to bounce back from it? Like what kind of self-care do you guys perform right after work?
Yeah. He's the only one that has it on there.
I guess I'll start. I feel like COVID kind of ruined our coping because we would normally just drink after work as a group to debrief. And I know that's not necessarily a healthy coping mechanism, but it was the most, I felt like helpful because it was immediate and it was with the people who were there that day and you could talk about it and then go home and have it be done. And not having that, I feel like has made it a lot harder. Things stay with you a lot longer. And it's just been, I feel like it's been a lot tougher and I've had to do a lot more therapy, honestly, true cognitive behavioral therapy to realize this isn't normal and it's kind of messed up, and just realizing the stuff we do isn't normal and it's okay to be a little messed up.
Yeah, I agree with Natalie. Debriefing with your coworkers is key. I think for me too is also learning to be vulnerable. Like, some days, like there was a shift that I had that I lost. Like I did end of life care on 3 different people in like 1 week, and I just like lost it. Just cry with my patient, I cry with my family, cry with my coworkers, and just understanding that you're human too, and it's okay to be vulnerable, to be upset, to tell people you can't take care of this patient again. But definitely just making sure you talk about the situations that you see with whoever that person may be, whether it be your coworker, your family. I think it's also good not like to let your family know what you're going through, because they don't really understand why you act the way you do when you get off work, because you just saw like the most horrific thing ever. And then other outlets I like to do is like walking and taking care of my dog, those things.
Yeah, I think everything is going to be individualized to the person. Like me personally, I really enjoy working out a lot. I like to ski. I'm getting super excited that it's getting cold out. I love hiking, but I think the importance really is having a good social network, having somebody that you can trust and confide in. And Elena brought up a really good point too. It's like I've always had difficulty trying to convey what my personal experience is so far, like at work, with someone who can't really relate, who's not in the field of nursing or medicine, because some of the things that we do and see are just incomprehensible to a lot of people. And the experiences that we have and the amount of death and stuff we see specifically kind of in our unit or the ICU specifically. So with my girlfriend, she's a nurse, and so we can relate a lot in regards to that. But not necessarily have to date or be with someone who's in that field, but to find someone that you can trust and confide in that field, who can understand your experiences, I think is going to be pretty powerful for you. And then 2, it's always okay if you're really struggling to reach out and to speak to like a therapist or someone who can maybe help guide you through those conversations, who can really help more so than just a friend who are going to tell you what you want to hear when you need to hear something, a little bit better to help yourself. But really finding those hobbies, I think, and having a good social network you can rely on. And not drinking too much alcohol.
Thank
See
you
that
so
bottle
much.
back there, Natalie.
I know, it's Patron. It's empty. Don't worry.
At first, I thought you had a beer, Joe. I was like, whoa, Joe. Just kidding.
Just a collection of corks from all.
We're all starting early here.
Our day off,
Yeah.
That's right.
When in Rome.
I guess day off, that's a very important thing. Like, be protective of your time and your emotional health. Don't stretch yourself thin, because this is a marathon. Don't feel like you have to be the hero and pick up all the shifts and take all the hard patients. Like, it's okay to say no, or like, it's okay to be like, you know what? I can't take that domestic violence patient. Can anyone else take it? Like, I just can't do it today. Or like, Elena, like, I've already had 3 end of lives. Can I please just have like the floor patient and someone else take it? You just got to speak up, and it's totally fine.
I have a question. Hi, my name's Katie, and I'm actually a first year student, so I feel like extremely ignorant to all types of nursing. But what does a normal day look like for you? And I know that's a loaded question, but like, what types of patients are you seeing? What types of diseases, and sort of like what types of interventions are you doing? I imagine it's a lot of medication.
So we work mostly in a trauma unit. So most of those people are going to be traumatic brain injuries. We have a really good neurosurge center there. So old people who fall, who are anticoagulated, for instance, they come in, we have to get some baseline lab values, see what their PT-INR is. If they're on some type of medication that would, precipitate their bleeding and anticoagulant, we have to figure out if we can reverse that agent so they don't bleed precipitously into their brain. It's followed by a lot of neurological examination, especially every hour at least, and more so frequently. Probably looking in their pupils, making sure they're moving all their extremities. Are they making sense? Can they phonate? It's going to be followed up by a lot of CT scans. They need, they see some sort of bleeding that's perhaps evolving. They may need to go to OR to have that evacuated. They come back, hopefully it's successful. More neuro checks, another CT scan, stuff like that. I mean, obviously that's just I'd say that's kind of the bread and butter of what we do, make sure that they're not getting, bleeding too precipitously, and rescanning them, doing frequent neuro checks. But I mean, there's a variety of things. I mean, a lot of it could be people coming in for the, most of it's just, you know, these hemorrhagic episodes that need to be corrected. And pretty much I say filling up the tank, figuring out where it's bleeding, doing something called TEG-based resuscitation, which I think is kind of beyond the scope of this, but you know, making sure that all their blood coags look good, repleting what they need, making sure they don't bleed out, and getting them to OR to fix what we can, and whether that takes more fluid or vasopressor, based off a variety of labs, which we can oftentimes order or resuscitate on our own, which is kind of the nice autonomy piece. But you know, I don't want to like kind of hog up this part of it, but that's kind of like a basic what I kind of think of what an ICU nurse is making sure that we stabilize the patient enough to either get to OR or kind of bridge them through that highly acute period.
Yeah, Denver Health specifically in our ICU, it's a level 1 trauma center. So it gets like a lot of the, like if it's a serious accident regionally, they'll still get flown in to Denver Health. And that's whether it's like revascularization, say like a cowboy cut his thumb up off like roping, they'll bring him here. Any type of polytrauma. So you're in a car accident and you break a bunch of bones and you have like liver injury. Like Joe said, like old people falling is a huge one, especially on anticoagulation. But being in the ICU itself, it's everything kind of follows guidelines because those patients will come in, whether by helicopter or ambulance, go to the emergency department, essentially get their like pan scan so that people know what's wrong with them. And then if something's too wrong with them, they've got to go to OR. And if not, then they come to us. And we basically, we normalize them and stabilize them as much as possible and get their labs within normal limits, whether that's giving them medicine, giving them product, stopping a bleed or something. And then we get them safe enough by data, and then they can either go and get their intervention that they need or just stay as stable as possible. So that's kind of our job. And we have 2 patients, but if they're really sick, then we just have 1.
And to add to that, it's like total care most of the time. So you're turning every 2 hours, you're doing their labs, you're running a bunch of medicine on pumps. You're also like, you're assessing, you're constantly assessing because you're the eyes at the bedside. So you always got to be able to pick up if something's going wrong with your patient and relay that to the doctors. That's really what I wanted to add is just like assessment. It's like a ton of assessing and a ton of drugs. Because you know, there's a lot of early signs that we can pick up if someone's not doing well, and it's key that if we pick up those things, we might save them from a big mess later.
Yeah, I'd say to like get into that too, like to get into the ICUs, it really does like behoove you to be a nurse for probably a couple of years, because there's 2 things that are kind of a little bit more accelerated in that environment, which is going to be your assessment, kind of like what Elena was speaking about. Like you have to really assess people very well, know what you're seeing, and detect little subtle clues that may indicate, you know, potentially like a pneumothorax or a tension pneumo, or just some of these weird little things that you really have to be thinking and have that critical piece established. And then also your understanding of pharmacology has to be really good, because there are a lot of meds, but a lot of these meds we have people on are on drips because they might have like absorption issues or something that we're not giving. We're holding a lot of meds in surgery specifically. So we're doing a lot of sedation at the bedside and pain medication. So knowing like your equal analgesic doses, knowing the mechanism of action, the half-life of certain drugs when you're pushing them, that's super important. And it's something that a lot of nurses probably don't understand as well or have enough reverence for, because it's super important to like understand that and know that. And I'm constantly looking these things up because I forget. Nobody remembers all this stuff. And we push all these drugs and they can have these weird interactions. So you really have to have that critical piece where you understand the assessment, their vital signs, and how this drug that we're going to put on board to solve whatever issue is going to affect the patient and those vital signs and their total course for their morbidity and mortality, which is pretty heavy when you think about it.
So then would you recommend, Joe, that like you start in a step down unit out of nursing school, or what do you guys recommend before going into a job like yours?
Yeah, I think yeah, that's a great idea, because you know you're going to have 3 patients. We're going to be a little bit less critical, but there's still potentially it could bounce back to ICU. It happens all the time. So you could kind of like get your foot in the door. You know, I'm not saying that there's one right way to do it. Like somebody could maybe do it, but I'd say like I'd be really struggling, you know, my first year or so trying to do that. I think that it's important to get that time management piece down, for sure, because that's the hardest part. I still struggle with that all the time. I want to like do everything 100% perfect, type A personality, but getting the time management piece, I think, is essential. Learning how to chart, learning what you're documenting, and people who are a little bit subacute, I would recommend highly.
I did 18 months on our 4B floor, which was like adult trauma. And like those people aren't on the monitor. And that's the important thing, is it makes you learn like, this person doesn't look right, and you don't have the monitor to back you up. And so you really have to follow your gut and know what not right looks like and what okay looks like. But a lot of people have different timelines for themselves. And I just said, like, I'll stay until I'm bored and feel ready. And for me, that was 18 months. And then I was ready to go to the ICU.
I started in ICU, but I do feel very passionate about getting your feet wet and starting on the floor. I think for me it was like super overwhelming, and it was like I had to learn all this stuff at once. So I think you can start in an ICU. I just think it takes a certain personality. You got to work really, really, really hard. But I do think getting your feet wet on the floor is probably the best way to set yourself up for success.
I'm a big fan of stories. So if any of you have like one single really memorable, unbelievable case, I would really love to hear, because I think people get really curious about that with the ICU trauma cases.
There's like only 3 people that stick out in my brain, but with like HIPAA, let me see. There's a admit that I had coming that was like, oh, here's what it looks like maybe this, and they rolled up. They didn't have an airway, like they were talking, and I watched them like actively go septic in front of my eyes, like modeling, dropping their blood pressure, like shit went down fast. And like people always talk about sepsis. I don't know if you guys have learned about it yet, or like septic shock, but it's pretty classic in our trauma patients. But to watch it happen within minutes and at an excruciating fast rate, and you have to stay on top of it, I was in that room. I didn't leave that room. I had the charge nurse coming up to the door to feed me like juice and pizza because I didn't leave. And we were on, and she lived, but like we were trying to stay on top of it. And you have to have source control for that stuff. And they wouldn't take her back to the OR because she would die. So we had to get her stable enough. And you're just racing against the clock. And so you have to be okay being like, in my mind, I was like, I am not leaving this room until she's stable. And I didn't. And she made it.
How long did that take by chance?
For her to make it?
Yeah.
To be okay. A few days. But they were able to find the source. And then once she was okay enough, they were able to take her back. But whenever the attendant comes in your room and says like, we can't take her back, she'll die, that's pretty terrifying. But it's early, especially.
That's pretty incredible. Thank you.
Yeah, I guess there's like 2 things that I can kind of think about. One actually just happened a couple of weeks ago, and I think it just kind of shows how awesome the people I work with really are. We had this guy who came out of the OR, and it was a motorcycle accident, I believe. He got hit like head on by a semi truck. It ripped his leg off. And then he survived the whole OR trip and the transfer and so forth. And then he comes out, and sometimes anesthesia will give them these vasopressors, like right when they come up to us. And then, they'll walk away. They'll be like, oh yeah, they did fine during the case. And they're very short acting, again, know your half-life of your drugs. You usually give them like phenylephrine. And then, this guy dropped his pulses, he went Brady, and then all of a sudden his heart just stopped. And then I was in there with just 2 other nurses, my charge, his name was Ian. And then there was one other girl with us. And then we're like, oh, do you feel pulses? They're like, no, I don't feel any. Super calm, just 3 of us in there. I'm like, okay, well, I guess we'll start CPR then. So they just started CPR, no one was freaking out. And I'm like, do we have any epi or anything? And they went and they grabbed some epi. No doctors are in the room at this point. And then we went through one round of CPR. We were about to give epi. And then we're like, oh, we got pulses back, we're good. Like no one was yelling, nothing was screaming. I was like, wow, that was flawless. Like, I mean, it was like one of those videos for like the American Heart Association. I was just so proud to work in an institution like that where no one yelled. We worked as a collaborative team, and we just basically, I was so proud of this nurse. Like she just basically saved this. She literally saved this guy's life, like right in front of my eyes. You know, it's really incredible to see stuff like that. And it makes you proud to be, you know, a nurse when you can see people actually do that kind of stuff. But I also love palliative care. And I remember I was talking to this lady, and I could tell she was really suffering. She was having trouble breathing. She had a lot of comorbidities, diabetes, morbid obesity, all this sort of stuff. And she ended up like breaking some ribs or something. She's a trauma patient. And I was like, do you like really even want to do this, you know, anymore? Like you look like you're miserable. I'm like, I can, it's up to you. Like you're the boss. If you want to keep fighting, I'm here for you, and I'll advocate for you, and we'll get you through this, and we can ventilate you and all this stuff. But it's probably going to require us putting you on a vent. And we kind of talked about that stuff. More appropriately, the doctor should have been talking to him about that stuff. But I wanted to have that conversation with her, and she's like, no, I'm tired. I'm miserable. I don't want to do this anymore. Like my life is horrible. And I was like, well, we can make you comfortable at least. You don't have to suffer through this. And we ended up transitioning her to palliative care and comfort care, and she ended up dying like the next day when we took her off BiPAP. And then a week later, I got this thing in my mailbox, and the family had actually planted like 10 trees in this national forest for me, or state forest in like Minnesota. And I was so taken aback by it. I was like, wow, like that is the meaning of like what this job really is. And you don't get that all the time, but I was just so blown away that like they could do something like that for me, just for trying to be there for somebody in like a time of need. And that to me is the most powerful, one of the most powerful experiences in nursing, and that you get in like an ICU, is you can have those really tough conversations with people and hopefully help them get through some of the worst times in their life. And then, the family sees that and appreciates that. I think that's really special.
I have two that come to mind. One was I worked in a neuro ICU, a cardiac ICU before I came to Denver Health. And then I had just pretty new to Denver Health, and I was on my own. Took a patient that was hit by a car, but he was really far out in Colorado, so it took him a while to get to us. He had a bunch of bowel injuries, so he had gone to the OR and his belly was open. And then he needed dialysis, so he started CRRT, and then his belly became like blue, and they're like, we can't take him to the OR. So then I had to do OR at the bedside. I'm like, so where is anesthesia? They're like, oh yeah, they don't come. And you're like, oh, so I do all the drugs. So you have to be the anesthesiologist, run the CRT, run all the vitals. It was like pretty insane. But he ended up walking back in there, and my charge nurse told me one day, like, hey, that was your first like good trauma save. And it felt pretty good. And it was pretty wild. I can't believe I made it through that. And he made it through that with me as his nurse at the time. And then the other one is also when I was at Denver Health. A patient was at a wedding and got hit and had a severe brain bleed, and he ended up becoming brain dead. Obviously never knew the kid, but for some reason just felt like this intense bond. He loved a lot of the same music I loved. He like was at my same age. It just seemed like if he was there with me at the time, we would have like partied together and had a great time together. But most importantly, I became really close to his mother, which you forget is like super important too, that you also are supporting the families through this. And before he went to get his organs donated, we took pictures together, which at the time like was kind of, it felt weird, like her son's like leaving and his organs are going to be transplanted, but she wanted to take a picture with me because of like the impact I had on her. And she later like wrote us a letter about how I helped her through that difficult time and like kept her like positive, like a positive light through the whole situation. So I second what Joe says, as far as like, I take a lot of pride in helping save people, but I also take a lot of pride in guiding people out of this world. It's just as important.
Thank you guys so much. Those are all awesome stories.
I have a question. What does ECMO look like from the nurse's perspective?
Like a lot of things can go wrong.
Like I
More, more alarms.
Can you explain a little bit about like what ECMO is for those that don't know?
Sure. I don't know. I briefly, I guess I'll talk about it. You guys can go off on after. But ECMO is extracorporeal membrane oxygenation. So essentially, what it does is it serves as this machine that oxygenates the person's blood outside of their body, and it's essentially cardiopulmonary bypass. So it goes through a filter. You have these huge, literally like garden hoses going through their veins. That's why it's very scary to me, because I just have like these horrifying nightmares that I'm going to rip something out, because I'm kind of clumsy, you know, so I don't like to take those patients because I feel like something bad would happen, and then, you know, I let somebody else do that. But no, they're very sick, tenuous patients. It's a one-to-one type of thing, and essentially you're taking all their blood out and you're putting it through this basically this membrane, right, that will oxygenate the blood, and that can be controlled. In our institution, it's controlled by a perfusionist, which is a specialized respiratory therapist. And these patients are always vented because they need PEEP or end expiratory pressure. And they have to be monitored very, very closely, so that we can essentially like give their lungs a break, and hopefully that they can heal, especially with some sort of traumatic injury to the lung, or most notably, I think, using ARDS to bypass and let the lung rest. But yeah, very complicated. It requires extra surgical interventions. The tubes themselves have to be put in the OR, the cannulation of the ECMO catheters, and it needs to be managed by very experienced nurses, very experienced RTs, so that they can precisely kind of dial in all the things going wrong with not only the ECMO unit, but also the ventilator, watching their vital signs very closely, taking labs, specifically like arterial blood gases, to monitor the titration effects. And that's why I say a lot of things can go wrong, because there's a lot of very expensive equipment and a lot of tinkering, and anything from mechanical or obstructive issues, clotting, a lot of things can happen. So you need very experienced clinicians to manage that type of equipment.
I think from a nursing, am I on mute? Okay. From a nursing perspective, I feel like they're a little bit extra challenging because the way that they're rounded on is different. The way that they're like handed off is different. And it is like RTs are definitely I feel like the head people in charge in that room. And so when doctors around, like you really have to be like, hey, I have an opinion, I have a thought, because I feel like they like really look over the nurses for an ECMO patient. So if you're like, I think this person needs pain medicine, they're like, okay, what does the RT think? So they're a little extra challenging to advocate for, I feel like, and things are a little different with them just by the sheer fact that they have these giant cannulas and they are on ECMO. And these people do still get road trips, which is the most terrifying thing ever, because the equipment that is ECMO is about like half the size of a room. So it's like a 1980s computer that you have to like fit into an elevator with this patient, and you can't go any faster. Like everyone has to be hands-on. So you have to be a really good communicator to be like, okay, we're not moving until this person says so, and you have to be pretty firm. So there's good and bad things about it, but I typically don't like taking them, but I've had them like 3 times.
Yeah, our last ECMO patient, just speaking to like the acuity of those patients, our in-house pulmonologist, he was at the bedside with those guys. He actually went down for the road trip, which is like unheard of, having a specialist pulmonologist go with you. They were in that room on my last day shift for 3 to 4 hours, just at bedside, you know, kind of tinkering. So there's a lot of cooks in the kitchen when it comes to that. So I can definitely empathize with Natalie. They're kind of like, okay, nurse. Yeah, that's funny.
All right. Does anyone else have any questions before I ask a second one?
Jump in real quick. In regard to what you guys were just saying regarding the RTs and stuff, do you feel appreciated by like the trauma surgeons and stuff on your floor, or that you are a part of their team rather than the nurses versus the doctors?
100%. I mean, regardless of what I said about ecmo, ecmo is such like a different thing, but that's kind of part of the like beautiful part of our job is we have direct communication like with everyone. So that's on the floor, like you're calling an intern and that's all you have access to. And then they'll call their upper and then they'll call their upper. And like worst case, they'll call their chief, but you're talking to the attending, like you have the highest resource available at your fingertips and they are really respectful and they work together with you and you're in a true situation where you're collaborating. And even in like a core situation, they'll be like, any other ideas, like anyone else? And it's like a fair game. Like a tech could speak up and be like, what about this? Like there's no egos or no like structure. It's like we all know what each other's roles are, but it's a true team environment and everyone can have a thought and talk up.
Yeah, there's definitely like some differences in personalities, but you'll get that everywhere, right? But I think in terms of allowing us to be able to collaborate with people, in general, they're pretty receptive. One thing I found that's interesting is like it's totally different from the floor, kind of like Natalie alluded to, in terms of like the respect for your ideas. And again, it's larger because like you know how to communicate now with doctors and physicians and you know other members of the interdisciplinary team and you know what you're asking for and how to ask it and kind of what their red flags are, their trigger words that makes them want to escalate care or do an intervention on their part. But yeah, I mean, I really like working there because especially if you gain trust with people, they'll really be receptive to your ideas. And, you know, it is kind of like that. Well, what do you think we should do? And I'm like, the first time they asked me that, I was like, wow, they actually respect me. Like they actually want to know what my opinion is. So that's pretty cool. One thing I find is that's interesting is like some of the residents, if they don't really, they're not comfortable yet, they're more defensive and they're less open to your ideas. Whereas someone who's like an attending is like, yeah, actually, you know, I'll think, yeah, I might think about doing that or something. You know, it's really interesting. So I think it's just kind of like a personality defense mechanism, in my opinion. But yeah, I think that in terms of openness and collaboration, being in ICU, you'll have the most direct contact and respect with your interdisciplinary team.
Kind of another question with that. How do you work with newer residents specifically during that transition in July?
Oh, that's a rough one. I personally have like tried to take a different role in it and is like I am help raise them as well. Like how can I teach these guys? July is like terrible for us. That's when the new residents rotate. And so they go from like their first year to their second year. So now they think they're big dog because they're not on the floor anymore. They're in the ICU. And you get all kinds of different personalities. Like you get the ones that are like scared to do anything. And then you get the rogue ones that just order whatever they want. So it is really difficult to kind of like navigate those personalities. But like Joe said, you get the defensive ones and things like that. And a lot of times, you know, I've learned a lot more patience and trying to just like help lead them to the answer. But then there's some of those ones that you can't really, they just won't be receptive to that, even trying to teach them. So you definitely get the difficult ones, and I haven't really figured out how to navigate those guys. But I've definitely, this year, I've had a lot of them, which was pretty cool, just like asked me so many questions. Like they were so scared on rounds and they like had no idea what they're doing. And they like literally just told me like, I don't know what I'm doing. Can you help me? And like, we teach them so much, and it's amazing at how little they know sometimes. And then to watch them grow, like when they come back, and sometimes they come back through and you see them and you're like, wow, you really actually did okay. I was pretty worried about you in the beginning. But it's very difficult. I don't really think I have a great solution. I just try to be patient and help teach them, and yeah, that's what I have.
Yeah, patience is definitely a virtue, and it's hard. I go in between and out of like, oh, and I should be more patient with this person. And basically what it comes down to for me is, and again, not saying that I know all the answers, but there's some things that I definitively know will like improve this patient's outcome. And so the first thing I'll do is like, if I'm working with a new resident, is I'll kind of ask them questions that I already know and kind of like test their knowledge and see like where we're at and what's happening. in terms of like their thinking. If it's something that they're ordering that I'm confused about, I'll be like, okay, can you educate me about that? Like, what's the process behind this? What's your thought on this? How is it going to improve the patient's outcome? And if they know, they'll tell you with a smart answer. And if they don't, they'll just kind of beat around it, and you won't know. If it's something that can hold on for like 12 hours, it's like a minor change in a medication or something that's not going to affect like the patient's total outcome or morbidity, you can probably wait, and you don't have to, die on every hill. But if it's something that I need kind of now and it's like a pain thing, I kind of throw it back and I'm like, is this like how, you would want, your dad? Like, would that be okay if like this was your dad or your mom right now? Like they were screaming in this kind of pain? Like that just doesn't make any sense to me, and if it's really urgent, you can always escalate, it wouldn't go all the time. But if you really think the patient's in danger, you have the right and the authority to go above them. And hopefully it doesn't have to come to that, and it can be more collaborative. Like, I think kind of like Elena said, I was surprised too by how little they actually know. Like I've been teaching a lot of the residents like how to use an EVD, what I figured they just all knew that, but a lot of them don't. And then when you can teach them and they can help you and it's collaborative, that's when you have the best relationship.
Yeah, I think playing dumb is a really smart tactic, because then you're like, oh, what's that? And then they have the chance to kind of explain themselves. But also these people have gone to school for like all these years and have like this whole like encyclopedic range of knowledge. And we're in this like to be honest, like quite specific ICU where like we kind of have the same sets of meds and we kind of have the same like way of doing things. And so it's kind of like it might be harder for them to kind of like figure out from their mind of all these pieces of information like how to dissect it. So I'll just be like, well, normally we just do this, like just for your like just kind of leaving that here for you to do what it is. But at the end of the day, you are still there to keep the patient safe and be their advocate. And if you don't feel like you're able to do that with your resident, then I make sure to like ask them a question in front of the fellow who I have good rapport with, to be like, okay, like that way that's kind of like there's someone listening to their answer to make sure it's okay.
Yeah, the other thing I would say is like knowing how to navigate it is probably the biggest challenge. And so like your charge nurses are great resources for that if you're not getting the things you need and they're not listening to you. We have nurse practitioners on our unit too who are always there, so they're also really helpful. So sometimes I'll be like, hey, this is happening, can you just like walk up to the bedside? And a lot of times if you can just like bring people to your bedside, and you have that a talk again, you'll get the resident to kind of get on board and understand why you're doing what you're doing, or why you want what you want.
Does anyone else have any questions?
I have a question. My name is Jessie. How do you handle the bad days? The days that you may lose one or more patients and it's just a bad day. How do you navigate that?
Well, I cry, which I think is okay to cry and be vulnerable. We had touched on this earlier. It's just like knowing your boundaries as far as like you can't handle that patient, or you can't handle that kind of patient again the next day. Making sure you talk about the situation, take time to like take your days off. I like do not recommend overtime when you first start becoming a nurse. And also like, we had a July one year where we lost so many people in 1 month. Multiple terrible situations, a lot of young people. And so we all kind of started talking about it, and it was like, everybody was actually hurting. So we ended up having a major debrief. We had like doctors come, we had some, this group called RISE, they like resiliency and stressful events or whatever come. And so we ended up like all sitting down together at a round table and basically just like discussing the situations that happened. And that was a great like debrief for all of us to kind of let out our emotions. But I just have to talk about it usually.
Feel free to be like, I'm going to go take a walk off the unit. Or if your charge nurse is going to send you home, just accept it.
Mm-hmm.
I was sent home at like 4 a.m. after keeping a kid alive to be able to donate one organ after like using up all the hospital's epi. And he was basically a 4-to-1 just to get him to the OR to donate, to meet his parents in like the hallway before he went. And it was like the saddest situation ever. But then like I came back and I was just like scrubbing blood off the IV pole out of like complete inability to do anything else. And my charge Jonathan was like, go home. And I was like, okay. So I like cried the whole way home, of course. And was just like, what am I doing crying? Like his parents are probably bawling. Like, what am I doing crying? So it's a little tough. But also I was in like a brain death test in the room as a new nurse. And like the family members weren't even crying. So I was like, I felt like crying, but I was like, Jesus, now like keep it together. Like you can't be the one crying in the room and like the aunt's not crying when like her niece has blown her head off. So like keep that shit together. But also then let it out. Just in an appropriate place.
Knowing when to walk away and like letting your coworkers help you, like, you know, putting somebody in a body bag is not really, it's pretty morbid. And I've definitely like made sure that I support my coworkers. Like if I'm like had a great relationship with this patient, like, hey, let me do the end of life care. Like, let me put them in the bag for you. Let us help you. So like, if they offer to do something for you, you just accept it, and knowing that you cannot handle that. And when you need to walk away and you just tell people like, I gotta go, and you just let people help you and you let them do the work for you so you can just go take a break and take 30 minutes, get yourself together and come back.
Yeah, I think like I've always rationalized it as, you know, these bad things are going to happen whether or not you're in that environment or not. And at least you can be there with that person and do everything that you can. I go home and sleep pretty well, full knowing that I did 110% that I could for that person, and I tried everything I could. And you know, it wasn't because of some atrocious error. That's just kind of how the world is. It's a cruel place sometimes, and I think it's an honor just to be there and to try to help and give 100%, you know, because a lot of people wouldn't do that and step into that role to try to save somebody, or be there to comfort them. One thing I've been doing recently is when I do have a rough day, before I turn on my car and I go home, is I take a minute and I just do some deep breathing, and I just kind of like recap my head and I just turn off for a second, you know, and I think that helps me to at least like rebalance and not get all worked up and into like some sort of mode. But I think prayer too is really important if you're a religious or a spiritual person, and, you know, just asking for help and knowing that you're struggling, or you know, just to guide you throughout your day, I think is very comforting for myself and for a lot of people. And I think just taking time to self-reflect and just try to let go a little bit, you know, because it's going to be hard. It's a lot of days are really tough in that environment, you know, but you have to learn how to kind of be objective and take care of yourself too, by not letting it invade, you know, your own psyche.
Thank you, guys.
All right, well, I think we will end it on that note. Thank you three so much for this. It was very, very enlightening and informing. Check your lockers. I'll put a little gift bag from CUSNA just to say thank you for your time. But once again, thank you everyone for coming to this talk. We do a talk once a month, usually on different topics of nursing. So always check your Facebook page, and we should have a new one out here shortly. So thanks again, everybody.
Sure. Have a good day.
Thanks. Bye.
Look, everyone.
Thank
Thank
you.
you.